Okay. All right, welcome to Soft Tissue Unknowns. So I've got 3 sessions with you guys, I think, over the next 3 Thursdays. So depending on how this goes and how you like the format, we can discuss what we do for the next 2. But since I gave like all the didactics last year, and those are all recorded, I figured I would do more unknowns. And as I said in the email, preview them, don't preview them, no low pressure, low stakes, but I want you guys to be able to, most importantly, sort of describe the morphology of what we're seeing, come up with a sort of, do you favor benign, do you favor malignant, and some sort of differential, and what immunoprofile would you sort of use to work these cases up. So who's going to be my first guinea pig to come and describe slide 1? Come on. And these are all, I think I gave you the histories. So does anybody have the email open with the histories? If not, I'll pull it up. They're all, I mean, yes, in soft tissue, age and site are important, arguably not quite as critical as bone, but
97-year-old male posterior thigh.
97 male posterior thigh. Okay, go James.
Okay, I mean, it looks like we have fragments of like a core biopsy here. On low power, I'm not seeing any skin, so I feel like we're pretty deep. And then kind of scooting around. I guess the first thing that kind of like strikes my eye on low power is you have this very cellular lesion with some kind of prominent vessels. You could argue there's some staghorning shapes here. They don't look epithelioid in normal morphology, maybe some occasional ones like this here, but they're not really moving any particular direction in terms of their orientation. You have areas where they're kind of more loosely kind of like put together with this looser stroma, and then there's areas where the stroma gets a little bit denser, but it still maintains this kind of like bubbly or vacuolated appearance. I think first impression is like, is this some kind of like a depositic tumor? We're trying to put it into a bucket in soft tissue. It looks high grade. You have like really big nuclei like that. You have like prominent nucleoli here. I saw like a bunch of mitotic figures yesterday. You have these like round nuclei. They get kind of like spindled or elongated. I wouldn't say they're quite spindled. Trying to see what else I can see here. Yeah, I get more of this kind of like vacuolated appearance. Some like hemosiderin or pigment here. So I don't know. I am having a hard time going beyond the like a depositic tumor bucket. So I know like with like a D-diff liposarc, you would see like potentially like heterologous elements too. I'm not really seeing that here. Well, I guess it's just D-diff liposarc versus pleomorphic liposarc.
Okay.
That's as far as I can go for the differential.
Thank you. Yeah, so basically a malignant spindled neoplasm with kind of myxoid to a sort of vacuolated appearance with some hemorrhage hemosiderin and no overt pattern, right, in terms of the layout of the cells, kind of patternless, and question mark a fatty differentiation. So in your differential of sort of malignant spindle cell neoplasms, right, a lot of times we are more often trying to prove what it is not, right, than prove what it is, because sometimes the diagnoses of these high-grade soft tissue tumors are kind of diagnoses of exclusion, all right? So with morphologic clues as to what they may be. So if you were thinking D-diff liposarc, which a malignant spindle cell neoplasm in the deep soft tissue of an old person is certainly possible, what what 1 or 2 or question mark 3 stains could you do to exclude D. difflipposarc?
MDM2.
MDM2, what goes along with MDM2? CDK4, and what's the third one that sometimes we use? P16. So there's many papers on how MDM2 and CDK4 are amplified, right, in D. difflipposarc. What chromosome are they both on? 12. Okay, they're both on chromosome 12. This might be, I'm telling you this for board's purposes, right? Because sometimes they ask this stuff. What happens to chromosome 12 in D. difflipposarc?
Like I don't know what it's called.
A ring, yeah. So that part of chromosome 12 where MDM2 and CDK4 are on get amplified, right? So many copies of the gene. And then the ends of it get sticky and they sometimes stick together, right? And they form a ring. Or they don't stick together and they're just a giant chromosome, large 12, okay? This is all stuff the boards is gonna ask you. So if you're thinking about D. difflipposarc, MDM2, CDK4, chromosome 12, amplification. Okay, sometimes P16 is thrown in there because there's one paper that says if you have at least 2 of those 3 positive in your tumor, that's predictive of amplification of that segment of chromosome 12, right? So MDM2 plus CDK4, MDM2 plus P16, CDK4 plus P16, right? Any of that combination. So you can throw those on here, and I will tell you that they're all gonna be negative. Okay, so this you by showing negativity, you've ruled out D. difflipposarc. Now you're asking about pleomorphic. So in pleomorphic, you want the fat, right, the adipocytic stuff to be intracellular. Do you think this vacuolization is intracellular or extracellular? Extracellular. Yeah. So when you perceive of the vacuoles as not really being in the lesional cells, we kind of favor less an adipocytic tumor. So if we're not favoring this to be an adipocytic tumor because the vacuoles are not intracellular, if we can't prove that it's D. difflipo, what are we left with? Are there any other entities on the morphologic differential diagnosis for malignant mesenchymal tumors that you significantly want to consider? MPNST.
Like a perfect Schwannian stroma.
No, doesn't have really marbling, right? The black and white area or dark and light areas. You can what's the problem with MPNSTs though, immunohistochemically? They often lose markers of nerve sheath differentiation, right? They lose S100, they lose SOX10. So you need the morphologic marbling, you need association with a nerve, or you need a history of NF1, right? To definitively make MPNST based on morphology and IHC alone, right? What else? Not much, right? It doesn't have fascicles like smooth muscle. It doesn't have any other overt cellular differentiation. So we're left with a undifferentiated sarcoma, right? So this is bread and butter. You're gonna see it the most common, right? The most common sarcoma you're gonna see in adult soft tissue is undifferentiated sarcoma, right? So names for it used to be called undifferentiated pleomorphic sarcoma, UPS, right? But not all of them are overtly pleomorphic. This is only sort of minimally pleomorphic. Used to be called malignant fibrous histiocytoma as the counterpart to BFH, benign fibrous histiocytoma, but that nomenclature is no longer accepted, right? But these are the things you'll see in the literature. So yes, this is an undifferentiated sarcoma, which we think has, basically the differentiation status of basically a fibroblast, right? It's got nothing. It may or may not have some myeloid markers, right? Like an SMA-ish thing, because fibroblasts and myofibroblasts are kind of interchangeable, okay? But other than that, there's no specific lineage of differentiation. There's no specific genetics, right? And there's no specific immunoprofile, right? So you're basically excluding based on morphology, and you're excluding the other known soft tissue sarcomas that this could be. Questions? Okay. I'll give you guys a break and I'll drive number 2 and then you'll take number 3. So what's the history for number 2?
42-year-old female lead mass.
All right, younger female, 42-year-old female with lead mass, okay. So now we see very cellular, right? And in this case, are the cells quite spindled or are they a little more plump? A little more plump. As with the other case, we see mites 1, 2, 3, right? So 3 in one field, that's no bueno. What other cells do you see in the background?
Giant cells.
Giant cells. What descriptor would you put on these giant cells? Are they Teuton giant cells? Are they wreath giant cells? Are they osteoclast-like? They're osteoclast-like giant cells, right? They're kind of small. They've got like 3, 4, or 5 nuclei. Nice pink cytoplasm, right? So these are osteoclast-like giant cells. Does this change, shift, alter, or impact your differential diagnosis of this tumor? So what are we thinking here? We've got plump epithelioid-ish cells in the background with lots of mitotic figures and osteoclast-like giant cells in the deep soft tissue of a 40-something-year-old person. What's your differential?
Giant cell, tumor, soft tissue.
Okay.
Giant cell, tumor, bone, depending on where the leg it is.
Okay, so GCT soft tissue or GCT bone. Does the number of mitotic figures cause you pause for those, right? Because those two are supposedly benign. There are some suggestions of giant cell, malignant giant cell tumors, right? But are those really malignant counterparts of giant cell tumors, or are those just giant cell rich undifferentiated sarcomas, right? I think that's the question. Okay, so I want to show you a couple of things. One is the histiocyte marker that highlight those cells here, and the negative mononuclear cells in the background, right? So just like giant cell tumor of bone, in this case, which are the neoplastic cells? Giant cells or the mononuclear cells? Or both? The mononuclear cells, yes. The mononuclear cells are always the lesional, the neoplastic cells. The giant cells in pretty much most soft tissue and bone tumors are bystanders, are like brought into the tumor. One, non-neoplastic bystanders, 2, neoplastic mononuclear cells. So I think this is CD68. The other pitfall with giant cell tumors, or giant cell rich tumors, right? Especially if you are in a deep soft tissue site, and we're gonna go back to James's original differential diagnosis, right, of an adipocytic tumor with maybe some kind of heterologous differentiation or co-opting of giant cells, right? You should always try to exclude like a D-diff lipo because that's easy with MDM2. So if you threw MDM2 on this tumor, this is what you would see. So how do you interpret this MDM2?
Like giant cells.
Yes, it's positive in the giant cells, okay? But it is arguably, right, negative in these background neoplastic mononuclear cells. You only see the MDM2 in these clustered areas of the bland nuclei that, oh look, God, that's a gigantic, really weird atypical mitosis, right? It's negative. So pitfall with MDM2 is that it stains nuclei of histiocytes and giant cells, okay? So always be careful what cells you're looking at to make sure you include or exclude a possible liposarcoma, right? So this is a great example of that. This can be relevant in things like osteosarc, right? Where you might have osteoclast-like giant cells. And we know that some osteosarcs, right, are MDM2 amplified. So always be careful what cells you're looking at. All right. So we have CD68 in the histiocytes. We have MDM2 only in the giant cells. And we have background mononuclear cells that are essentially malignant. So we can't really call this a giant cell tumor of soft tissue benign, right? Because the background cells are too malignant. We are in the deep soft tissue. We're not in bone at all, not even touching bone. Even if we were in bone, this would not be okay for a giant cell tumor of bone, right? That is also too overtly malignant. So we're dealing with a malignant thing. So, what's your diagnosis?
I was wondering with
I'll
all,
take the question.
with all
Yeah.
the all the blood vessel channels in the background, could
Uh-huh.
you think of something vascular like a angiosarc?
You could, this, to me, it appears to be kind of like extravasated small red cells rather than vasal formation. But that's, even in angiosarc, you don't have to have vasal formation. Usually angiosarcs maybe don't have quite this many giant cells, but sure, you could throw a CD31 erg on there. In this case, it would be negative. But yes, always when you see extravasated red cells or something that suggests vasal formation, easily do your vascular markers. All right, so this is one of the known morphologic variants of another undifferentiated sarcoma, right? That is just giant cell rich, okay? So if you pull up your WHO chapter on undifferentiated sarcoma, you'll see that giant cell rich variant is one of them, right? So we cannot necessarily prove that it is related to any benign giant cell tumors. It in and of itself just recruits giant cells. In giant cell tumor of bone, which is probably similar to what's happening here, what is the like chemokine or chemical or like ligand receptor interaction that recruits the giant cells into the GCT bone? Do you remember what that pairing is? Rank. It's rank ligand. Okay, so probably there's some kind of rank ligand thing happening here. We'll talk more about giant cell tumors of bone when we do bone, maybe next week. But it's probably something similar that's recruiting these, okay? It's a little bit young. 42 is a little bit young to have an undifferentiated sarcoma of soft tissue, right? But anything is possible. Otherwise, it doesn't morphologically have any other good differential diagnosis. What else? Questions? All right, somebody come up here and drive the next one. Thank you. And what's the history?
70-year-old male upper back.
70 male upper back.
So your pores are fragmented, large core, looks pretty. Some also areas of either like fibrous tissue or maybe necrosis at low power. High power, it's very cellular, it looks very spindled. We do have like these very large atypical cells, giant, almost eccentric nuclei that are around perinephric. It looks like it wants to be in fascicles in some areas. And then this looks like some muscle. Where did your muscle? And that. We have areas that are more cellular. I'm not sure if that's like artifact or associated with the lesion, and then some necrosis also associated with it. But so definitely malignant. I guess with location near muscle and some of, maybe you could argue, rhabdoid and spindle things if one are pull out something that's myogenic. I don't know, maybe you could argue this is an osteolytic giant cell. No, maybe, okay, maybe not. Yeah, so I'm thinking muscle origin, so I'd probably throw a few things on based off of that. And any other big pathognomonic things here.
Well, once we learn about what the muscle markers show, we'll talk. Okay, so what muscle markers would you want?
Maybe SMA, myogenic.
So, are you thinking smooth muscle or skeletal muscle differentiation?
I'm thinking skeletal muscle.
Okay, so is SMA going to help you with skeletal muscle?
No.
No. What cytoplasmic intermediate filament is going to help you with skeletal muscle differentiation? Myogenin is a nuclear transcription factor. What? Desmond.
Okay.
Right. So Desmond is smooth muscle, Desmond is skeletal muscle, Desmond is myofibroblast, Desmond is myoepithelial, right? SMA is everything but skeletal, right? So if you're thinking SMA is fine in this case, but SMA would show you fibroblastic, myofibroblastic, not skeletal but smooth muscle. Desmond would show you skeletal muscle, and the others. And then you said myogenic, right? So myogenic is also the most, right, specific for skeletal muscle, along with the other stain, which is the same protein but a different clone that we don't have here. MyoD1, exactly. So myogen and MyoD1. They bind slightly differently to the protein, so they are expressed slightly differently in skeletal muscle tumors. We have myogenic, all right? So I appreciate your concept of there are these large cells with eccentric eosinophilic cytoplasm that could be rhabdoid. So you definitely want to think about a Desmond and a myogenic. And in this case, they're negative. So no, right? So we don't have evidence of skeletal muscle differentiation. Myogenin and MyoD1 would be nuclear. Of course, Desmond would be cytoplasmic. Okay, so now we are with a pleomorphic spindle cell neoplasm in an adult. Now I'm going to point you to these paucicellular areas, right? So when you see these paucicellular areas with kind of this wispy material, what do you think about?
Carrot shapey. No, not carrot shapey.
You're not thinking about a neurofibroma. No. This is an outside consult, so the staining is a little bit not what we are used to, but what kind of stroma do you think is going on here in the background? Is this fibrillary, collagenous, myxoid? Myxoid, right? So maybe you don't see the connective tissue mucin because the stain's a little too pink, right? But when you have this rarefication, right, of the stroma and the cells splayed apart by this nothing, right? Always think about something quote unquote myxoid, or at least myxoid-like, right? Especially when you have areas where the cells are tighter and areas where the cells are looser like this. And where the cells are looser, think about something myxoid, not epithelial mucin, right? But connective tissue or stromal mucin. Okay, so we have no skeletal muscle differentiation. If you're thinking about, like you always should, DFSP, right? We're going to say that it's negative also for MDM2, all right? Because that's always something you want to throw on there, like we talked about. So what other types of tumors could have rhabdoid cytomorphology in soft tissue sarcomas? Undifferentiated sarcoma can have anything. Yes. What else though?
Also have a little bit of that in the Myxofibrosarcoma.
Okay, you can definitely have that in the Myxofibrosarcoma. What other group of tumors has rhabdoid cytomorphology that you always have to think about in every single organ system with rhabdoid cells? SMARC, right? So the chromatin complex remodeling tumor. So INI1, i.e. BRG1, INI1, SMARC, help me out here. INI1 and BRG1 are the proteins that are produced by SMARC A4 and SMARC B1. Thank you. Whatever, look it up. INI1 and BRG1 are the proteins, those are the immunos. So you'd want to throw an INI1 and BRG1 on here too. Would you be expecting loss or retention if this chromatin was affected? Loss, right? So in this case, it would be retained. What, if you're thinking about INI, BRG, lost tumors, what is the morphology usually of them? Is it more spindled or more epithelioid? Usually more epithelioid, right? So we're thinking more epithelioid sarcoma. So this doesn't perfectly fit, but with that rhabdoid appearance, you want to throw it in. All right, so none of those have panned out. What are we left with? Myxofibrosarcoma, right? So this is a high grade Myxofibrosarcoma, and you can see that it has this, a little bit kind of like storiformy or herringbony appearance in areas, and then in some areas, right, the cells are splayed apart. Again, I think you're maybe not appreciating so much the myxoid because of the staining qualities, but like that pallor, right, that pallor between the cells, that's kind of myxoid stroma, connective tissue mucin. So adult, elderly, diagnosis of exclusion, high-grade sarcoma with myxoid, whatever. If you called undifferentiated sarcoma, you also wouldn't be wrong, because basically Myxofibrosarcoma is just an undifferentiated sarcoma with some myxoid stuff, right? Usually these are highly infiltrative. They track along like fascial planes, so they can be difficult to excise. Usually patients are older.
Are they usually in the upper?
No,
They can be
any
anywhere, okay.
trunk or extremity deep soft tissue. Yeah. So upper back is usually it's limb, but trunk is fine too. Yeah. Okay. Thank you. Who's next? Thank you. I think this is a younger person. 20s, maybe 30s, 32.
Female, yeah.
Yeah, that.
So for this one, we have variable cellularity. We have some paucicellular areas or some little bit more cellular, moderately cellular areas. However, cells relatively bland, spindle looking. There is not really mitosis, necrosis, and the pattern is all like this. Not really, a little bit vesicular, not really distoriform or any, vascular to remind you. There are some small thin vessels. But I think that's it for the picture of this lesion. So I think the differentiation wise, I'm more thinking about like fibro, myofibro bucket. Like it can be either benign or low grade sarcoma something. So think combining with the myofibroblast bucket or question mark can be nerve sheath differentiation.
Sure.
For fibroblast bucket, I'm thinking about if benign is like nodular fasciitis,
Okay.
kind of thing. Low grade can be maybe Fibromyxoid, low grade Fibromyxoid sarcoma can look like this. And some like nerve sheath benign tumor can also look like this. So that will be different to the staining.
Okay.
That's to CD34 for the myofibroblast first. This up.
CD34 for myofibroblast?
So
No. What soft
SMA.
tissue tumor? SMA, fibroblast, myofibroblast, okay. And then what for nerve sheath?
Let's do SOX10 S100
Okay.
GLUT1 EMA.
Okay, so SOX10 or S100 for Schwann cells, EMA for perineurium. What you mentioned CD34, but you didn't mention the tumor. Arguably, it's less on the differential here, but what soft tissue tumor is CD34 strongly positive, or what couple of them?
Yes.
DFSP and SFT, right? So dermatofibrosarcoma, tuberans, and solitary fibrous tumor, CD34 would help you with. Does this have morphologic features of either of those, just since we're here? Not really. SFT, the nuclei maybe are a little bit more blunt and ovoid. These are a little bit like spindly, right, and kind of crushy. So not thinking so much SFT, but could be. So CD34, and what is the other thing for SFT? STAT6, right? Could come up on your differential for a low grade, kind of collagenous rich spindle cell neoplasm. Okay. We talked about nerve sheath tumors. Okay. We talked about fibroblast, myofibroblast. So the other thing, sorry, I'll grab right now. I'll point out is you nicely mentioned you can sit down, it's okay. The variation in cellularities, right? There are some higher cellular or moderately cellular and some lower cellular. In this case what is this ropey stuff in the background? This is collagen, yeah? This is not necessarily part of the cell, right? This is background collagen. And then these paler areas, which is arguably maybe a little bit of collagen, but also some of that characteristics like we were talking about in the prior tumor that's a little bit more bluish, right? Which is maybe a little bit more myxoid, okay. So if you do all of the stains that you asked for, your nerve sheath tumors would be negative, but there is a possibility, your S100 SOX10 would be negative, but there's a possibility that your EMA would light this up. Does that suggest anything to you? Perineurial tumor, okay, because EMA is positive in perineurial. What other tumor on the differential that was mentioned does this highlight? Does EMA highlight?
Fibromyxoid.
Low-grade fibromyxoid sarcoma. What is the other marker for low-grade fibromyxoid sarcoma? MUC4, okay, so, all right, this is MUC4. So, especially in a younger 20s, 30s-year-old person, like Myxofibrosarcoma said, when your differential diagnosis is like, is this a cellular benign thing? Or is this a low-grade sarcoma? Think about LGFMS, right? Low-grade fibromyxoid sarcoma. Some things that we didn't talk about on the differential, but if you have a sampling bias, right? And maybe you've sampled mostly a paucicellular, and maybe your differential diagnosis is a myxoma, right? Or a fibroma or something like that. You can still think about a MUC4, right? To specifically exclude a low-grade fibromyxoid sarcoma in a paucicellular myxocollagenous spindle cell neoplasm in a younger-ish, right, young adult person, okay? So in a case like this, you definitely would want to exclude all of the things, right, that were mentioned, but this is a low-grade fibromyxoid sarcoma. What's the fusion? FUS? Crab. So in the event of non-specific immuno or bad immuno, you can always try for the FISH or the RNA sequencing. What is so far for all of the tumors we've seen, are these patients more at risk for local recurrence or metastasis? Local, right? So mostly we're dealing with local recurrence. Sometimes these high-grade sarcomas can metastasize to like lung, right? But usually not so much. Usually it's local recurrence and local morbidity, okay? What's the tumor that low-grade fibromyxoid sarcoma could transform to that's high-grade? All right, that'll be your homework for next week. What can LGFMS transform to? Okay. All right. Questions? Okay, who's next? And those of you who've seen these skin, like, chunky outy things, half the time these tumors come to us from outside institutions as like, patient has a cyst on their leg, you know, right?
So it looks like have something that's maybe almost forming like a papule of the skin because of this large dermal infiltrates. It's very blue, but there are some areas where a little bit more clear here. Here it's forming smaller nest perhaps. Epidermis looks okay. It's very, very deeply infiltrative. So it's like superficial and deep dermis are both involved. It looks like this is the papillary dermis is spared. It doesn't really go up right to the epithelium. You kind of have a zone where it separates from this neoplasm. Grand zone. Tumor itself looks pretty spindled, pretty monotonous, or maybe more elongated rather. It's in a vaguely like story form pattern. But the cells themselves cytologically are fairly bland. Seeing through here, I don't really see mitotic figures. I don't think I saw necrosis. This is Is this? I don't even know if these are cells, honestly.
Whoa,
Oh, they are cells.
they are cells, they've
These are
got nuclei.
melanophores. Okay, interesting that you have melanophages this far down. So with this differential or with this morphology, I feel like the differential may be somewhat broad. You could be looking at this could be fibromatosis.
Okay, what else? It's, you mentioned something earlier, which was it's both superficial and with deep extension. So with a spindle cell neoplasm involving skin and deep, what should you always say?
DFSP.
DFSP.
Probably would throw on some melanocytic markers as well, just given that
Pigment.
pigment that we saw.
Yeah.
These vessels, not too many of them.
No,
I don't think that's necessarily it.
No.
Like a fibrosarc
okay, okay,
morphology,
okay.
some collagen on here.
All right, good. So we have a differential and we can start ordering some stains. So what stains do you want? You want your melanocytic markers, fine.
CD34.
CD34.
Do an SMA, beta catenin.
For fibromatosis, okay. Okay, let's start there. All right. So what about the first thought that you have, which is fibromatosis? What about this is different from fibromatosis conventionally?
Not really the long sweeping fascicles, more like storiform pattern.
Yes, right. So fibromatosis, more long fascicles, more pink, right? Arguably somewhat less cellular because there's fewer cells and they have more cytoplasm, right? They have long fascicles, so not quite what we're thinking, but fine. SMA beta catenin, you can think about it. Melanocytic markers, in this case, would be negative, and there's no evidence of any overt, superficial melanocytic proliferation, although, melanomas can have skin-to-skin metastasis, right? So you can have dermal mets of melanoma where there's no overlying in situ component, so fine. But your key here, right, is your three things, right? A few things. The proximity to the skin, the storiform, kind of tightly fasciculated morphology, the basic blandness of the nuclei without many mitoses, and this honeycombing entrapment of fat, right, which is sort of a buzzword. This tumor doesn't push the fat aside, it entraps it, and it has this honeycomb appearance. So even without a stain, this is DFSP, right? So this would be diffusely strongly CD34 positive. This is DFSP. If you're thinking about in your skin, right, if you're thinking about dermatofibroma would not be this deep diffuse or infiltrate fat like this, and it should be CD34, essentially negative or very weak, only at the periphery, all right? So DFSP. What does this pigment mean anything to you in DFSP? There's a variant. What's the variant's name? Pigmented DFSP, or the eponym is Bednar tumor. Okay, so I know we're getting away from eponyms, but you may read this in the literature, right? So quote unquote Bednar tumor is pigmented variant of DFSP. So yes, this is fine. This is all fine for DFSP. What is the risk in these patients? Local recurrence or metastasis? local recurrence, right? So these things need to come out with wide margins. What is the high grade variant of DFSP? Which you sort of mentioned. Fibrosarcoma, right? So DFSP can have fibrosarcomatous transformation. What does fibrosarcomatous transformation look like? So you start to get much more cellular, right? Much longer sweeping fascicles. What's the pattern, the buzzword name for this type of pattern? It's not storiform, but it's herringbone. Exactly, right? So these very long, very dark fascicles. So this is beginning to be a longer fasciculated herringbone. And then you start getting mitoses, right? So 1, 2. So this is fibrosarcomatous transformation of DFSP. Now the patient is at risk for distant metastasis. So once you make a diagnosis of DFSP, right, which may be somewhat more like up here, right, with sort of shorter fascicles, honeycomby infiltration, right? Don't stop there, right? Always ask yourself, can it be worse? Can you have fibrosarcomatous transformation? And it's important to report that because they will stage the patient with PET scan for mets and they will work up, right? This will progress differently. So hypercellular, long fascicles, mitoses, and the thing that often comes along with this is weakening or loss of CD34, right? So those are kind of your clues. Peter and I have struggled with some cases where like it's slightly cellular, it definitely has mitoses, but it's like still storiform and it retains CD34. So like, is this progressing, right? Is this progressing to fibrosarcoma? So like always kind of evaluate these things critically and describe what you see, right? Because sometimes it's a gradient. And sometimes it's an overt, like, boom, this is a fibrosarcomatous area, right? Okay. Yeah.
Keep the molecular.
It keeps the molecular. What's the molecular? Collagen, PDGFB, exactly. So yes, it would retain the molecular. If you only saw fibrosarcomatous area, which probably you wouldn't because there's usually always a background, that would be proof that it came from a DFSP. True fibrosarcoma in isolation like this, either in an adult, right, either arises from a DFSP or is basically like a variant of an undifferentiated sarcoma, right, if it doesn't arise from a DFSP. What's the other setting in which fibrosarcomatous morphology can occur? Not in an adult. Infantile fibrosarcoma. What's the genetics of infantile fibrosarcoma? ETV6 and TRAC3, exactly. It's one of the TRAC. Yep, exactly. Same as salivary secretory carcinoma, same as papillary, exactly, right? So we have these overlaps. So yes, infantile fibrosarcoma, NTRAC, adult fibrosarcoma, DFSP, collagen, PDGFB. Okay. All right. Questions? Yeah.
For a fibrosarcoma that there's no like known history or evidence of the DFSP precursor, would retention of the fusion sort of indicate, okay, maybe it was like from a DFSP versus like, if you saw fibrosarcomatous morphology from like undifferentiated part, you would most likely, you wouldn't have like.
Correct.
Okay.
Correct. Exactly. So yes, in rare cases, you can see this morphology without the fusion and without a DFSP. In that case, it's basically, it would be just undifferentiated high-grade sarcoma, cellular type. But yes, if you saw the fusion, it would definitely be from a DFSP. Okay. Want to go next? Anybody? Hopefully starting with biopsies is helpful, right? Because I think this is where the diagnoses are made.
Two cores, looks a little on the bluer side, maybe moderately cellular from the go. Doesn't look like any necrosis or like differentiating areas. It all looks relatively similar. Going down, to me, this starts looking like the outer surface of like vessel, and so that like I have my diagnosis that I thought it was a myopericytoma, which is like whirling around some vascular areas. None of the cells to me looked overtly malignant. I didn't think I saw there's some right there. Didn't think I saw any sort of mites in here either. These right here, like whirling around, and gave me like it's like radiating out from something, and that's its growth pattern. So kind of like myopericytomas, or I didn't think I saw pecoma type things, but it gave me a similar feeling of growth.
So in essence, what are the myoid cells that surround vessels in their mature form?
But I thought it was like muscle.
Yeah, basically smooth musceloid differentiation. Yeah. So, did those atypical nuclei bother you for a benign thing? Yes. Yeah. Right. So the subtle nuclear enlargement and hyperchromasia would be a little bit bothersome for like a benign parasitic thing. There are these symplastic glomus tumors, right, that can have this bizarre nuclear atypia, but does this have the cellular morphology otherwise of a glomus? Not really, right? It's more spindly myoid, right? It's more spindly myoid. Okay, what else is on anyone's differential? If we're thinking about myoid. Are we thinking specifically that this is a perivascular myoid tumor, or are the vessels incidental to the tumor? What I would ask, right? So if the vessels are incidental to the tumor, then what are we expanding our differential to? To all the smooth muscle stuff, exactly. Myo. Is that a mitotic figure right there? Did you just land on one? Right here? Yeah, I think so. It's a little blurry, but it's got little fingers. All right, so perivascular myoid or just true smooth muscle. So generally the perivascular myoid stuff is either extremely bland, right, and sort of round cell glomoid, or if it has mature myoid elements, usually there are some immature glomoid elements. Or if it's all mature myoid, you wouldn't expect this much pleomorphism, right? So unless it's a malignant variant, but those are vanishingly rare. So I'm thinking something more sort of true smooth muscly, okay? And I think one of the things I wanted to point out is when you ask yourself, you know, is the pink that I see collagen pink, or is it like intracytoplasmic, like myofilament pink? Sometimes you can sort of see a subtle difference, right, between the like bright pink that's right next to the nucleus and the like slightly paler pink that's outside of it. So I know this is a scanned slide and it maybe those characteristics are less prominent, but even in areas like this, right, you can see a colorimetric shift, right, in the pink, where there's a really dense pink coming out of the nuclei, right, and there's like a paler pink in the background, right? So that to me is good evidence that this stuff next to the nucleus is probably true intracytoplasmic, more brightly eosinophilic myofilament, which means it is myoid or smooth muscular, right? I know that it's subtle, but hopefully you can make that. And when you look at your slides under your own microscope and you can focus up and down, right? See if you can see that pink shift, right? Because that subtle pink shift tells you, oh, that's intracytoplasmic myofilaments. This might be actually smooth muscle. Sometimes smooth muscle also has these little cytoplasmic vacuoles, right? So that can sometimes be helpful. Usually the nuclei of smooth muscle also are these kind of elongated, right, or cigaroid shapes, right? So in this, and you can sort of vaguely see like fascicles, right? So traditionally, fascicles of smooth muscle are like intersecting at 90 degrees, right? So you should see some coming out at you and some coming across the screen and some cut at weird angles, right? So if you see this kind of intersecting like medium length fascicles with that eosinophilic cytoplasm, Okay, think about smooth muscle. So if we agree that morphologically this is a smooth muscle tumor, we can prove it with SMA, Desmond, Cal-Desmond, Calponen, all the things, they're all positive. Now what? Benign, malignant, right? So in soft tissue, this is malignant. This is not uterus, right? This is not a stump. This amount of atypia and even 1 or 2 mites, right? This is at least a low-grade myomyosarcoma. This is the resection, which, you know, in areas shows this stromal kind of degenerative-y type of change, right? But in the periphery, we have these nice recapitulation of that eosinophilic fasciculated morphology with these sort of oval, blunty nuclei. So myogenic sarcoma. In the areas over here are maybe a little bit closer to maybe what we saw in biopsy, where you have these like fascicles. One interesting thing that came out on the molecular, I believe, of this tumor was it had MDM2 amplification. So now what?
Sorry.
It could very well be a liposarc with myogenic differentiation, right? So I don't think MDM2 was done on the original biopsy or even the resection, because there was no background fatty tumor, and it was so overtly myogenic and so arguably sort of bland, right? It didn't scream D. diff lipo. But now they threw molecular on it and it has MDM2 amplification. So it could be a D. diff lipo with myogenic differentiation, because we know that is 100% possible. If you were in the retroperitoneum, that would inevitably be the answer, right? It's always D. diff lipo with heterologous. In the deep soft tissues, though, like, you can get other non-lipomatous tumors, right? Some of which can stain with MDM2 but not be amplified, in which case they're not lipos, right? And some of which are amplified. So you have to ask yourself, is this really a lipo? And look for potential background fatty stuff. In this case, I don't think they sent much background fat. So I think it would be very hard to evaluate, but you know, things like this start to raise a possibility. Maybe you throw an MDM2 IHC on here and see what happens. So my lesson learned here is always just do an MDM2.
Was the biopsy signed out as myogenic sarcoma then, or like
Low-grade lyo, low-grade leiomyosarcoma, which yeah, I would have also.
Obviously for low grade, like prognosis would be better, but let's say like it was called, or you got an uglier area, it was called high grade or like leiomyosarcoma. What is the different, or like, I guess, what would they do different clinically with that versus an undifferentiated liposarc with myogenic?
Basically, probably bigger margins.
Okay.
It's always usually primarily surgical. With rare exception, if it's unresectable, they'll give neoadjuvant, but usually it's surgical. With a low-grade lyo, they'll probably be a little more conservative on the margins. With a high-grade sarcoma, they'll probably be a little bit more generous on the margins. And they would probably stage the patient for mets. Even though metastasis on presentation is unlikely, it's still theoretically possible in any high-grade sarcoma. So whether you call it high-grade lyo, high-grade lipo, whatever, they'll probably resect. I mean, it's essentially the same. They'll resect with clean margins, wide margins, and stage for mets. Yeah.
So characteristically or classically, they tell you that leiomyosarc in the retroperitoneum is a primary differential. So is it that now we're learning by molecular that most of these are actually MDM2 amplified?
Many of them are MDM2 amplified. The primary leiomyosarcomas of the retroperitoneum are usually or by definition would not be MDM2 amplified, and generally are associated with a large muscular venous vessel. So it's thought that they actually arise from the myogenic layers, right, of the vasculature. rather than the myogenic liposarcs, which kind of arise in the fat, right? So those two things, MDM2 and is there a vessel? But they do, they 100% do exist. But they're generally associated with a vessel. All right, it's 8:59. We can stop here and we can do the rest next time? Okay, great. Cool, thank you guys. Was this format good? Okay, so we keep this for the next two? Okay, thank you.
So much undifferentiated.